Welcome, everyone, to this Center for Global Development webcast on safeguarding access to sexual and reproductive health care during the COVID-19 epidemic. Governments around the world are continuing to focus on the COVID-19 outbreak head-on to prevent already stretched health systems from being overwhelmed. But as the pandemic accelerates, we also have to pay attention to other essential health services that are at risk of interruption from COVID-19. These kinds of knock-on effects or crowd-out effects are driven by supply-side challenges, including supply chains, stock-outs, health worker shortages, as well as demand-side obstacles, including travel restrictions due to lockdowns, fear of seeking care, and of course, drops in income that are related to the economic shock that affect people's ability to spend on transport to health services or paying for other kinds of medicines, things like that. Some examples: back in March, the family planning service provider DKT was already reporting stockouts of implants in Myanmar and a condom shortage in Mozambique due to reported doubling in delivery times from manufacturers. These indirect effects of the pandemic, which could cause just as much, if not more, illness and death than COVID-19 itself, we know this from previous outbreaks, has a disproportionate effect on women and girls who face other gendered impacts of the outbreak, including school closures, increased unpaid care duties, we're living that ourselves, and increased gender-based violence. Sexual and reproductive health and rights are especially at risk due to structural barriers to access, including increased rates of unintended pregnancies, unsafe abortions, and maternal and infant mortality, and that creates long-lasting effects for women and girls. So it seems obvious that pregnant women will continue to need maternity care, prenatal care, access to contraception, and these services can't be delayed. So we're seeing, unfortunately, reports from various countries that these delays are happening. Ranging from Uganda and Ethiopia to China, the challenges that pregnant women are facing due to disruptions to transport, lockdowns, diverted staff. In several states in India that already had extremely high maternal and infant mortality rates at baseline, outreach services for sexual and reproductive health care have been halted. And while available projections vary because of underlying assumptions, all suggest that the impacts could be substantial. Researchers at Johns Hopkins are estimating about 113,000 additional maternal deaths in the first year of the pandemic. Guttmacher is estimating up to an additional 49 million women with unmet need for contraception, 15 million unintended pregnancies, and 3 million unsafe abortions over a one-year period. So without concerted efforts, disruptions along the entire care continuum and supply chain may endanger the delivery of these essential services. So today we'll be discussing the role that policymakers, donors, the private sector, and other development partners can play in protecting and sustaining the hard-won gains in sexual and reproductive health through the pandemic and beyond. And beyond today's event, CGD is doing ongoing work to look at many of the health system challenges associated with COVID-19. We'll be looking at the net health impact of the COVID-19 policy response and associated economic shock, the trade-offs between implementing COVID-19 outbreak containment strategies and what happens with these other essential services, as well as an early alert system for shortages of non-COVID medical supplies. And lastly, building on global evidence suggesting that the inclusion of contraception in publicly subsidized health insurance or health coverage schemes, we are working on a framework to assess inclusion of contraception in health benefits packages within a broader health financing paradigm. And we plan to explore how development partners can better support and incentivize governments to protect public spending for cost-effective sexual and reproductive health services during the economic crunch ahead. So with that, I'll pass it over to today's moderator and organizer of this session, Janine Madan-Keller. She's the Assistant Director of the Global Health Policy Program and a Senior Policy Analyst at CGD and the brains behind this operation. Thank you.
Great. Thank you so much, Amanda, for sharing these opening framing thoughts, reminding us all why the topic of today's conversation is important now more than ever. You highlighted a lot of important dimensions of the current crisis that I hope we'll have a chance to delve into during the conversation. So without further ado, I want to turn it over to our speakers, who we're really delighted to have join us for this session today. So I will introduce each of them, asking them to share some of their opening thoughts and reflections, unpacking the issues Amanda highlighted. Then following the initial round of comments, we'll have some time for open discussion amongst the speakers. And then last but not least, I will leave time for questions at the end. So for those of you joining us from around the world live today, please send in your questions to us throughout the conversation. You can add them in the YouTube feed. You can also tweet at us. Our Twitter handle is @CGDev, or you can use the hashtag CGDTalks, or you can email us at events@cgdev.org. My colleagues are behind the scenes. They'll be fielding your questions and sharing them with us throughout the event. So I'd like to start by turning to our first speaker for today, Dr. Monique Vletter. She is the practice manager of the Global Financing Facility at the World Bank. Monique, drawing on Amanda's remarks, I'd love to ask you to reflect on where you're seeing some of the biggest challenges that GFF partner countries are grappling with as they confront the adverse impacts of COVID-19 on access to sexual and reproductive health services. And could you tell us a little bit more about the GFF's current efforts to support partner countries in maintaining these services, and how you're seeing the role of the GFF within the broader universe of other global health partners and development partners? So over to you.
Great. Thank you so much. And first of all, thank you so much to CGD for organizing. This is such an important topic, and I'm really glad that we have the opportunity to have this conversation. I'm also delighted to see the other speakers. They're all partners, collaborators, and particularly Dr. Selma from Nigeria, who plays such an important role in the response there and is very much part of our service delivery community of practice. I'm delighted to see her also on the screen. And there is just no question that the COVID-19 pandemic is also triggering a secondary health crisis, and it's leading to widespread disruptions in access to reproductive, maternal, newborn, child, and adolescent health and nutrition services. And we are incredibly concerned about that. Since the start of the pandemic, we've done our own rapid assessments in country, and as early as end of March, early April, we started seeing these disruptions happening in the majority of our 36 partner countries. And this is really jeopardizing the access for women and children to access family planning, antenatal care, attended birth, and other essential services. We're also very concerned about the supply chain disruptions we're seeing and the challenges that health workers are facing, particularly in the front line, because of the lack of protective clothing and the interruption and availability of important supplies in primary care facilities. So there's really no doubt that this is a major problem, and it might by itself have a larger impact than the COVID itself. And, we find that absolutely unacceptable. And so as part of the response and as part of the GFF partnership, we're focusing on 3 areas. One of them is to engage with our partner countries, the 36 countries, around the in-country coordination, advocacy, and prioritization of what needs to happen, not just in response to the COVID pandemic, but particularly also for maintaining essential services. And then we're working with many of the 36 countries to really do a deep dive into the practical planning around what is necessary in the front line to maintain service delivery. And this is what kind of actions do we need to take to protect health workers, to triage, to have infection control on facility level, to separate COVID infected with non-infected patients, etc. And we do that with through different tools, through our liaison officers, to the partnership platforms in country, but also through our community of practice, where we're pooling together twice a week policymakers in a subset of countries to really help ensure that we can jointly plan and that we can learn from each other's experiences. We're also heavily engaging on the supply chain. I'll leave it up to Prashant to talk a bit more about that as we're doing that in collaboration with him. And we're looking at ways of investing in joint investment with the private sector to make protective clothing available for frontline health workers. And finally, on the demand side, it's really important to realize that we understand why are we seeing these disruptions. It's not just because of supply side constraints. We're also seeing major challenges on the demand side of people being afraid to access services. And we're looking at ways and how we can, through communications and other actions, can ensure that women feel the confidence that they can access services. And none of that can be done by one player by itself. And so this is very much a partnership agenda. And I want to also just say something before ending, specifically around the sexual and reproductive health agenda, because that's just so important. And we very likely will see major impact on the utilization of family planning. We've done our own analysis of that in the 36 GFF countries. We estimate that there will be more than 26 million women in just those 36 countries that will be unable to access family planning, which can lead to 8 million unintended pregnancies. And so really a major problem and a big concern. And so we're making 5 policy recommendations around this. The first of all is change clinical protocols for provision of self-administered family planning, ease restrictions on over-the-counter dispensing of SRHR and other health products, engage and contract private sector outlets, including pharmacies and drug shops, to meet essential service needs, engage health technology and delivery innovators to help expand access to essential information, products and services in non-traditional ways, and expand demand-side financing, such as digital coupons and vouchers, to improve equitable access. So at the GFF, we are very committed to do everything we can to ensure women, children and adolescents can continue to access SRHR services during the pandemic. Protecting access to modern family planning is critical to reducing maternal and child mortality, achieving better health outcomes and gender equality. And we can't let the pandemic turn this back. Thank you.
Thank you so much, Monique. Lots of important points to unpack, and I think indeed several colleagues are spotlighting the fact that the indirect effects of the outbreak response can be just as significant, if not worse, than the direct toll of the virus itself. So building on this global view that you just shared on these adverse impacts and the GFF's ongoing efforts, I'd love to turn now to Dr. Salma Anas-Kolo. She is the director of the Department of Family Health in the Nigerian Federal Ministry of Health, and she's joining us here today. And I'd love, Dr. Salma, to ask you to share some of the realities and implementation challenges in Nigeria that you and your colleagues are grappling with. Could you reflect on Amanda and Monique's comments and tell us a little bit more about how you are seeing the pandemic impact women and girls' access to these essential services? And where do you see COVID-19 amplifying and magnifying some of the long-standing obstacles and barriers that these communities have faced? And if I can squeeze in one more question, also to hear how you and your colleagues are thinking about modifying service delivery approaches in the current context. Over to you.
Thank you very much, Janine, and I want to appreciate the organizers of this very important forum. It is very timely. For us in Nigeria, it is really affecting us seriously because if you look at our work, where we stand prior to COVID, we are not yet there. We are struggling to improve access to reproductive, maternal, newborn, and child health, including family planning, with a lot of resistance, with a lot of challenges. But we've made modest progress in the last few years, which we still have a huge gap. So with the COVID, it is very sad that it is impacting negatively, especially on women and children. When the initial case was reported in February, around the end of February, it continued to rise within a very short period of time in an alarming rate. And then now almost all the states of the Federation are affected. We are recording almost more than 10,000 cases despite the limited testing. And community transmission is now over 80%. So this has greatly impacted on how we deliver services, especially essential and routine RMNCH services, including family planning. Women are not accessing services. If you look at the clinic side, on the supply side, health workers were so scared at the initial period of it. They were scared of coming out to deliver services. The restriction also does not allow them to have access to their workplaces. And they also complain of lack of availability of PPEs to protect themselves. And then commodities are also not there because we have disruption of family planning commodities and all other commodities, including consumables, because of the lockdown. And then on the other side, you hear from the populace, the clients, the women and their families, because of the restriction, they do not have access, and they also have that perception that services are not continuing. So a lot of problems happen, and a lot of confusion, I would say, happened as of that time. And then the capacities, nobody knew how to go about it, how to handle cases of, how to handle women with that, whether they are COVID positive or not COVID positive. So there was a lot of scare and a lot of confusion around activities. So what we did was to try to interact immediately with our focal points and coordinators at the state level. And we observed that there was a decline in women coming for antenatal clinic in the facilities. And then the number of women also delivering at facilities drastically reduced. Women are not coming to deliver at health facilities. 3 areas we looked at: the accident and emergencies. Also, there was a drop in visits in that area of it. So this came out very clearly as some of the shortfalls. So what we did was to immediately have a high-level strategic engagement, which was led by the Honorable Minister himself, calling all the state commissioners of health who lead health sector response and also RMNCH activities at the state level to ensure that we continue to deliver services, because we are going to have collateral damage. So what gains achieved in the last few years will all be disrupted, will all be eroded. So this was sound to all the managers of health and then the coordinators of health and all health institutions in the countries, because SRH services are usually delivered at all the levels of healthcare with so much attention now and focus on the primary healthcare facilities as part of the approach adopted to achieve the universal healthcare coverage. So all agencies were directed to do that, and then we started engaging at that level to ensure that capacities of health workers are developed. Health workers, especially those responsible for services and the family planning services, are involved in the coordination mechanisms at the national and also state level so that they have a better understanding. And also to avoid diversion, because part of the challenges we had initially, health workers were diverted to work on the COVID response, either as case managers or in the isolation centers. So this also created a huge gap. And if I may mention, prior to COVID, we've had a serious challenge of human resources for health. So with the diversion of health workers, again, at this time, it added a serious burden on the health sector. So this was also curtailed. It was stopped at currently. And then we also begin to mobilize additional health workers, especially the retired nurses and midwives. A lot of states started re-engaging them because they are still very active, but they retired very early. So most of them are services. And then we also embark on a lot of awareness creation activities, which is a key component of our risk communication management, to inform people, the communities, that services are still there, services are still available, adolescent-friendly services are still ongoing. We are not closing shop, because this is something that we had to emphasize, because most people have the impression that services have all stopped. It's only COVID services that we are being offered. So these are some of the modest activities that we made. And then with regard to family planning, as I mentioned earlier, we had a lot of challenges because of the disruption. We could not even move commodities to the site. The last mile distribution was significantly disrupted. Then we had to now come back to that again and then ensure that the Honorable Minister obtain a waiver for all health workers and also all people involved in the logistics of transportation and delivery of family planning commodities. They got a waiver, and now they are able to transport family planning commodities. In the last 2 weeks, we were able to push family planning commodities to all our state, and we also ensure that they also distribute those to the service delivery points. So these are some of the few activities we've been able to do. And then at the higher level, we continue to see how we can improve our coordination of activities. We try to rally our development partners and continue to meet on how do we better improve our services and ensure sustenance of the services. So currently in Nigeria, we started working on a health sector response plan, and a critical component of the health sector response plan is the sexual reproductive health action plan. How do we work differently within this COVID period to ensure that we sustain our services at all the levels of care, most especially at the primary health care facilities, where a majority of vulnerable women and adolescents and girls and as well as children access services. So this plan is currently ongoing at the moment, and then we have all our stakeholders participating in it, both at the national and also at the state level. So this is the current discussion that is going on in the country as a way of ensuring that we secure and sustain services in a non-stop manner. As we always say, nobody knows when COVID is going to leave us, but we are hopeful that it's going to leave us. But services, the act of, as we say, producing children does not stop. And then we don't want to be burdened with unwanted pregnancies that will result in unsafe abortions, and also increasing the maternal death, and also if they eventually have to deliver children, and then the children do not have access to quality care or even immunization services were initially disrupted. So these are part of the focus that the Nigerian government is focusing at all the levels of care in the country. Thank you so much.
Thank you so much, Dr. Salma. Bit of an echo, if I can just ask others to mute themselves.
All right, thank you.
Thank you. Thank you so much, Dr. Salma, for sharing those really rich on-the-ground perspectives from Nigeria and highlighting for us the additional burdens on pre-existing obstacles and challenges that COVID-19 is posing, from healthcare workers as well as for transport for essential medicines and other products. So I'll come back to some of these points later on in the conversation, but now I'd like to turn to Dr. Marianne Etibet, who's lead and executive director for Merck for Mothers, as well as a CGD board member. Marianne, we know from existing research that in many low and middle income countries, a large share of the population often turns to the private sector, to private pharmacies, to drug shops and chemists to seek health products, and they're often having to pay out of pocket to access these products, and this is especially true for contraceptives. So building on your experiences across the private, public, and nonprofit sectors, but also your work leading Merck for Mothers, I'd love to ask you to share what you're seeing as some promising ways for innovative financing, but also for platforms and tools like mobile tech innovations, public-private approaches, and how they can help promote better service availability and affordability. And to bring it back to COVID, if you could reflect on both the challenges but also the opportunities that the current crisis is posing for these existing but also future efforts in this space. Over to you.
Great. Thank you so much, Janine. Thank you for the invitation. I'd like to say hi to Prashant, Monique, and nice to meet you, Dr. Salma. It's really great that CDG is having this conversation, because I think what the perspective that you bring to what's going on right now in the world is not just how we make the right decisions for the moment, but how we make the right decisions in the moment for the future. And, you mentioned some of the work that Merck for Mothers has done in innovative financing and how that can either inform or help us think differently about our responses to COVID. And I'd like to link that to the fact that, all of the work that we're doing, whether it's the Ministry of Health in Nigeria, whether it's the World Bank Global Financing Facility, all the work that we've been doing in the years and months leading up to COVID, those are the investments that we've made in health system strengthening that ideally, would help us weather the shocks, of COVID. And so I want to speak, to some of those based on your question around innovative financing and the link to availability, affordability, quality. And then I also want to add the aspect of access. So in terms of availability, Dr. Salma, you mentioned that, one of the things that the ministry has had to deal with is the need for increased healthcare workers, human resources for health, and how you've had to divert and redeploy workers within the ministry. I do think that the private sector can be a place to augment capacity in the health system. And we're already seeing that play out in COVID, whether it's here in the United States or countries across the globe, where local private providers, whether they be physicians, nursing homes, midwives, pharmacies, as you've mentioned, supply chain distributors, many, of that sector has really stepped up, raised their hand, and are looking for ways to help governments respond to COVID and augment their capacity, for this response. And their ability to do so is based on some of these previous innovative financing investments. And I'll share one that Merck for Mothers is involved in through our Moms Initiative partnership with the U.S. Development Financing Corporation. And, that's a $50 million initiative to provide growth capital, debt financing blended with grant financing to social entrepreneurs so that they can scale. And we know that this ability to scale and scale quickly we're seeing the necessity for it in COVID, but it's also going to be critical for us to meet our SDG goals. And so the ability to bring in new capital, new private financing to support local private sector and social entrepreneurs, is critical for the COVID response. The other thing that it does, and I can't remember if it was Monique or Dr. Salma that mentioned this, but we are investing in local economies. And we know COVID is having a huge impact on economies. When we think about our response, we should also be thinking about how it can help to fuel and jumpstart local economies. The second point you mentioned was around affordability. And you're right that a significant proportion of women and adolescents seek services with local private providers. In many countries, in many states in Nigeria, it can be up to 60 or 80%. And depending on where you are and the out-of-pocket costs that consumers may need to pay to augment services, in the public sector, our ability to invest in financial platforms, whether they be health savings accounts that can blend funding flows from health insurance schemes, from donors like Merck for Mothers, pool together out-of-pocket costs, pool together potentially employer insurance. That pooling of money on digital platforms allows for increased affordability and increased access to services. And I think a lot of the impact investing in innovative financing, as you mentioned, in mobile tech and fintech, will allow for this rationalization and hopefully efficiency of funding flows. The third point was around quality. And I think we need to be very careful as we respond, in the moment to scale up services around COVID, that we are also paying significant attention to quality. We know, through studies from the Lancet have shown that 60% of the deaths that we see in around primary care maternal health are due to lack of quality, not necessarily lack of access. And so a lot of the innovative financing mechanisms have an ability to tie payments to quality and to outcomes. And I think that that's something that we should continue to make sure happens through this emergency response. So we are not shortchanging ourselves, and more importantly, shortchanging patients who are seeking services. And last but not least, I'm actually happy all of the folks on this panel have already discussed the important demand side of this equation, because it's not just the lack of supply of services that we're seeing have an immediate impact on poor health outcomes. I think, Monique, you mentioned, predicted models predicting 100,000s of women dying due to lack of access to high-quality maternity care. We are already seeing from data on the ground, which I'm sure you're aware of, dips in service utilization, 40% reduction in seeking antenatal care. 40% reduction in seeking institutional delivery care. And a lot of this, as my co-panelists have already mentioned, is because women and their families are scared. They don't know when to seek services, how to seek them safely. And as Dr. Salma mentioned, the ability of personal protective equipment to be available wherever they seek care, whether it's the public sector or private sector, we know that there are huge gaps there. And so I think what COVID has taught us, not that we didn't already know this, but it's really emphasized, is that health systems don't stop at the facility. Health systems stop at the patient, at the person. And so as we think about our responses, as we think about how we strengthen health systems, we need to really make sure that the connection between people and patients and facilities are there and are strong. We're seeing, huge increases in the deployment of technology that allows for real-time communication between patients and their providers and facilities. We need to, from my perspective, double down on this and make sure that those technologies are scaled so that patients can get the right information at the right time that's specific for them, so that they can seek the service that they need in a safe way. And this is something that I'm excited that COVID is actually surfacing because there's a lot of work that we can do here. And I think that there's a lot of opportunity for innovative financing mechanisms to help scale these new types of technologies that will closer connect patients and people to the health system. Thank you.
Thank you so much, Marianne, for highlighting some of these health system strengthening solutions and reminding us, much like our other speakers, that it's incumbent upon us not to let COVID exacerbate the disparities we're already seeing in health outcomes. So finally, I'd like to bring in my CGD colleague, Dr. Prashant Yadav, who's Senior Fellow at the Center, to dig a little bit more into some of the points that Monique, Dr. Salma, and others have raised around supply chain disruptions. So Prashant, can I ask you to describe a bit what the different types of supply chain disruptions that we're currently seeing both at the national and global levels, and if you can also help us think about some of the unique effects, particularly for SRHR products in this space. And as a second part, as we all think ahead longer term beyond the immediate response to the long road to recovery, I'd love to ask if you could also reflect on how the current situation can help us think about the role of the global health architecture and system in sustaining supply chain needs going forward, particularly around managing some of the risks that the current crisis has really brought to light. So I'll stop there and over to you, Prashant.
Yeah, thanks, Janine, and thank you very much for putting together a great panel and a group of colleagues and collaborators who have worked extensively on the issue of SRH access. I think we all know that the global supply chain for medical supplies has been disrupted significantly due to COVID-19. There are two kinds of issues. One is for certain kinds of medical supplies, demand has gone up, and for other kinds of medical supplies, just the supply side shortages have become more problematic than they have ever been in the past. So I think the larger global disruptions are things that are occurring for a wide range of medical supplies, where I think SRH products in particular are at a higher risk is many commodities within SRH are not purchased using a global procurement architecture like what we see for HIV, AIDS, TB, and malaria or vaccines and so on. And as a result, there isn't a clear global agency which is looking at supply chain risks at the global level in a systematic manner, identifying them proactively, exchanging stock, etc. We do see some of that happen for family planning and contraceptives, a subset of SRH commodities, where the Reproductive Health Supplies Coalition, UNFPA, others have put together groups. And these are not groups that are created only for COVID-19, but have existed before for coordination across manufacturers and purchasers. So they are helping a lot in managing and rebalancing supply and demand. But that doesn't exist for a subset of SRH products, such as medical abortion commodities, many other things. So that's one global risk, which is not having the right architecture to rebalance. Then I think as we look at data, we feel there is still enough supply of contraceptives and also of other SRH products in the system today for public purchasers. But we don't know if this is a time lag effect. What I mean by that is it just that we had enough stock and buffer in the system because of which we are able to manage, but because incoming supplies have been disrupted, will we see the effects of this in the months to come? So at CGD, together with colleagues from IQVIA, MyShaMeds, other groups, we are creating a data-driven method to help identify where the risks are the most significant of a country-level shortage occurring for specific molecules and items, including SRH. So that will help us give some more time to think about what the mitigation measures are and where should we prioritize. Then I think, you asked about, what are some longer term fragilities in the supply chain. So I think we know that we've started investing in data systems for supply chain for SRH commodities only, relatively recently, at least at the global and national levels. And I think that's an area which could help us both proactively prevent some of this and also figure out new ways to mitigate them quickly. Then I think I want to highlight two additional things. One is that the private sector channel continues to be a very important point of access for lots of women and girls to access SRH. And when we think about needs for protective equipment and PPE, when governments are collating their orders and placing them in the supply side market for PPE, we know is very scarce at this point. I want to make sure we are including the needs for health workers who work in private clinics, pharmacies, drug shops, many other forms of private sector service delivery. And if we don't include them, our risk of shortage of PPE will then translate into a service disruption risk in the private sector. So just something to highlight. And also, can we organize how they purchase their PPE in a somewhat more aggregated, somewhat more pooled manner? Then I think Monique had started mentioning this, but needs for PPE, both for the public sector health professionals, but also in the private sector and community health workers, there would be ways to shorten those supply chains. So instead of largely focusing on purchasing using long supply chains where manufacturing occurs in Asia or another low-cost production base, can we start doing some more local and regional production? So I think GFF, IFC, other colleagues have already started exploring that. I think that is a very positive trend and can give us, not just for PPE, can also help us resolve shortages through regional manufacturing of other SRH items. The last thing I want to mention is there are many social enterprises who have gotten in the business of distributing essential medicines in the private channel. Some of them are focused on SRH, such as e-pharmacy models or some kind of e-commerce distribution models. In many countries, they are the ones who are becoming the mainstream source of providing continued SRH access. So it's a reminder for all of us in the global architecture that how can we create financing vehicles so that such social enterprises for distribution of health products can be a more integrated part of the health system. And COVID-19 has given us an opportunity to think about that in a somewhat broader way than we have in the past. I'll stop there. Thank you.
Thank you so much, Prashant, for picking up on many of the earlier comments that colleagues made that I wanted to delve into deeper as well. So now I think it's a good time to open up for a broader conversation amongst our speakers. I think there's a lot of things to unpack and very much encourage you all to react and respond to each other's comments. But maybe let me start by picking up on what I heard as a recurring theme mentioned by several of you around the sort of demand side of the equation. I know Prashant talked about some of the supply chain challenges, but I wanted to go back to the demand side of the equation and particularly to some of the points that Marianne alluded to earlier about the private sector being a really important channel for SRHR services and products. And Marianne, you highlighted the importance of making sure we're connecting people with services and facilities and doubling down on this going forward, not just in light of COVID-19, but also more broadly in terms of other goals. So I wanted to pick up on that point, and I think there has been some momentum around thinking about, as you mentioned, digital health platforms, but also around community-based care, as well as information campaigns to ensure, as Dr. Salma was saying, that women and girls know that there are still services available for them to access. So I wanted to ask if you can, maybe we'll start with you, Marianne, to reflect a little bit on why it's so important and how we can ensure that these efforts are continuing to be informed by evidence, but also, I think more importantly, appropriately tailored to the context in which they're operating, acknowledging that, as many of you said, we're trying to scale these really quickly, trying to deploy them in a really quick manner. And just to maybe add one more point is, I think to echo, I think some folks' worry in this space that where some of the risks of adverse effects may be the highest, it might be especially difficult to roll out and implement some of these programs. So how can we make sure that these efforts are not exacerbating existing inequities, and how can we keep an eye on making sure that, the most poor and the most vulnerable communities have access as well?
Yeah. No, thank you so much, Janine, for the question. And that's, what challenges all of us and the discussions that we have with our partners. I want to say, first of all, that there, as Prashant alluded to, that there is such exciting work already going on ground in a very organic way. People are stepping up. And I do think part of the responsibility we have is how do we, one, understand that that's going on, and two, amplify and support it, and then three, link it to institutions and, systems so that it can actually flourish and grow and be sustained. To your point around the cultural relevancy, and again, I think this is why it's so important to invest in local communities, whether it's the community-based organizations, whether it's social entrepreneurs, because they are living in those same circumstances, understand that intimately and understand how to navigate. And to your point around equity and reach, many folks can serve as intermediaries. So while you may not be able to get to, you may need an intermediary or two in order to really reach that last mile. And I think we can be intentional about those. And even with deployment of technology, you have many examples where there are intermediaries that have access to technology and link that, to community groups. One of the other things I will say around, but the opportunity, and I think we have during COVID with this increased awareness of the disparate impact of COVID and highlighting the disparities that we already see, is that there is, I believe, a groundswelling of momentum and mobilization around this. And so we do have that opportunity to ensure that these digital platforms, mobile phones, etc., as we think about our interventions, we're also intentional about digital inclusion and financial inclusion and collaborating across sectors, so health with banking, with the folks who do financial inclusion. How is it that together we can ensure that these resources and these platforms are actually reaching that last mile? The point around cultural competency, again, we have partners who, and I'll just give this one example, we know that we oftentimes have a hard time reaching youth and having behavior change with youth populations. And, they're just great examples of, a platform called MIVI doing exactly just that and engaging youth populations around conversations around COVID and what they should be doing. You also mentioned community health workers, and I want to come back to that really important point that Prashant made about PPEs. In the maternal health space, there's a huge role that community health workers, traditional birth attendants play. And we need to ensure that they don't just have access to PPE, but they're integrated into programs or initiatives or resources where there's training and capacity building on how to use PPE appropriately, and how to use it in the context of service delivery. It's not just about giving a mask to someone and thinking that you've done the job appropriately. There's a lot of other steps that need to happen to ensure that, the use of that PPE has the intended effect. Thank you.
Thank you so much, Marianne, for, I think just wanted to pick up on your point about the need to amplify what we're learning, both in the current context, but also what we know from previous outbreaks, and to underscore the point about the importance of including private providers in thinking about response plans, both in terms of how governments are thinking about this, but also the role that development partners can play in helping to think about these issues. So maybe with that, we can pivot to your point about learning, and I can turn to Monique. Would love to hear from you, Monique, on how you're seeing opportunities for GFF partner countries to learn from each other and share what's currently working, what's not, and the role that the GFF can help play in facilitating shared country learning in real time.
Right, and thank you. And that's a super important question. Before I go there, I just want to build on what Marianne was saying about, it's really about putting the woman central, right? And so think about the local context, the needs, and put that central. And this is, if you just think about the implications of what we are discussing here, the situation has so massively shifted. And so even when you think about the forecasting that we would have to do for countries like Nigeria or other countries, in terms of what is needed pre-COVID and now, we will see a complete change in the methods that women will access, how they will access, etc. And I think we just really need to internalize that and think about this also as an opportunity to do things differently. And I'm just thinking about the gender implications of how in this shift we can actually think in a more transformative way. How do we make services more responsive to the needs of women, right? And so that could be around telehealth. In many countries, women still have to walk a long way and wait 5 hours before they can be seen, right? So is this an opportunity to think about women and their livelihoods in a way that is much more empowering and more modern, right, than it has been before? And I mean, I'm personally also really concerned around the donor dependency in terms of the financing of family planning commodities, and that just want to put that out there as sort of the sustainability and the domestic financing for the SRHR agenda is incredibly important now more than ever. Now, on the learning platform, and it's all interrelated, we have for a long time had an experience with a learning platform and a community of practice where we really see our role more as facilitators to allow for a safe space for countries to exchange. As we see in terms of the innovations really taking place in the local context, and there's incredible value for countries to be able to exchange and learn from each other, much more than having experts coming in and doing speeches, etc. And so building on that and realizing that we had a completely unprecedented situation when the pandemic happened, we extended that by saying, okay, we cannot travel, we cannot have joint meetings, we cannot work together. Let's make this more action-oriented. And so we had 10 countries that volunteered, and we're focusing heavily on service delivery, bringing them together twice a week and really exchanging in small groups and between countries on what needs to happen, what is the data that we're seeing, where do we see constraints in the commodity availability. And it also has allowed us to really gain a lot of insight what's happening in these countries and better tailor our other support, whether it's financial or through analytical work or technical assistance, better tailor that support to the needs of countries. So thanks for raising it. It's been incredibly exciting and sort of a new virtual way of working on development that is still really bottom up and driven by countries. So thanks.
Thank you, Monique. Indeed, we're all learning by doing here in the current context. So I wanted to circle back and bring Dr. Salma back into our conversation. Dr. Salma, I just wanted to open it up back to you to reflect on the many relevant points that colleagues have brought up, specifically around, putting women and girls center, thinking about longer term prospects of some of these modified service delivery approaches, and how you're thinking about the role of some of these development partners in supporting countries like Nigeria, but also countries in the region and beyond. So over to you.
Thank you very much, Janine, and thanks to all the speakers. I very much agree with what was said, especially with the private sector engagement. Just like what was mentioned, more than 60% out-of-pocket expenses, and then the private health facilities play a very great role in Nigeria, especially where women access services and children. So maybe I didn't mention, the private sector has been actively involved right from the beginning of the pandemic. They were the first to step out to contribute money to the response at the national level. And this is still ongoing. So they play a very great role. And part of the engagement that we did at the highest level also, which was led by the Honorable Minister, was engaging also with the private health facilities through their organized platform. And all activities that are being implemented currently, which include the capacity building of health workers on IPPs and all service delivery aspects, also include the private sector involvement. Though we don't have much of the PPEs, but they are playing a great role also in supplying PPEs to health workers. So this is highly appreciated, and we continue to encourage it. Recently, we've also been having a lot of discussions around local manufacture of PPEs. In fact, at the moment, a lot of private, because we are not having enough, it's still not adequate despite the support we are getting. Despite the government limited resources and then support by partners, it's still not enough. So private sectors are also encouraged, which we've been doing and advocating through the trade industry. And a lot are currently producing a lot of even sanitizers, the face masks, the gowns, and several other protective equipment at the moment. So this is highly appreciated also, and I'm happy with the discussion made, and I will continue to explore through the Ministry of Health, through the partners of GFF, how we can get innovative approaches to work better with the private sectors. Then looking at how do we properly position the woman, I think it is very important that the woman is at the center of it. So what we always felt, I personally felt, despite the COVID, there are opportunities that also will unfold. I mean, this is the first time that it has clearly exposed the weaknesses of the health systems in Nigeria. And the good thing that has happened is that the top level policymakers, the stakeholders, the communities, the religious leaders, community leaders have seen the weaknesses in the health sector. And everyone is trying to see what responsibility, what can we do to make it better. So as far as we are concerned in the Family Health Department, we felt this is a great opportunity that has unfolded right at the community level, because now we are telling community leaders to take responsibility in ensuring that despite the COVID response, women and children still continue to have services. They should continue to create this awareness. We've had forums where through the National Primary Healthcare Development Agencies and also at the state level are talking to religious leaders to ensure those linkages, and also to take personal responsibilities in providing and in encouraging healthcare providers to continue to provide services and advocate for protective measures. So we feel this is a great opportunity that has come, and we have to make our best use of it in terms of programming. Most of our healthcare providers, most women do not access services. If you look at the overall context in Nigeria, most women are in the communities, and then most are provided by community health extension workers, community health workers, and then the community volunteers themselves, because they are the first point of contact to every woman in a community, to most women in a community. So most of these women reach the traditional birth attendants, though we've done a lot of work to discourage deliveries by traditional birth attendants, but we still try to divert their energies in the right direction to ensure that they are the first contact. They link them up with facilities. They provide them with adequate information. So even traditional birth attendants, which we are now redefining their roles, we are not allowing them to take deliveries, but they also require PPEs at that level, because they are the first point of contact. They are the ones that the women will go to ask for information, to ask even. So they are also involved in our programming, when we are trying to do more in terms of ensuring that community volunteers are not neglected. They are informed, they are trained on how to provide information to families and also to women, and how to lead. Opportunities, I said, are unfolding in terms of now, unlike before, everybody is trying to be an advocate for health, especially for the health of women and children who are the worst affected. So I think this is a time for us in the history of our time that we make the best opportunity out of it. And the best opportunity out of it is for us to be able to harness all the efforts together. This is where the development partners come in, where we require a continuous technical assistance in terms of having an effective coordination and harmonization of all these efforts to make the maximum impact. So as I mentioned earlier, we're trying to attract a lot of our development partners to see how we can leverage these opportunities. How does it work better for us? For instance, if you take family planning, of course, it is the basket funding that happens in Nigeria, which is led by UNFPA. It's still, we do a lot of advocacy and struggle to ensure that we maintain even and commit and make commitments of the government counterpart funding. Year in, year out has been a challenge. But in the last 2 years, 2017, 2018, government have been able to meet those commitments. But it requires a lot of energy and advocacy to do that. But recently, we are beginning to see a lot of changes because of attention has been diverted now to health, have focus on the health sector. So recently, even with the meager resources, despite the COVID pandemic and then the resources that are going into the pandemic, we are all happy to see that the Honorable Minister of Finance herself is so much committed to ensure that the funding for family planning remains as it is. It's not touched. It's not diverted to the COVID response. And this, so far, as of today, as I'm talking to you, is still within the revised budget, because we keep on revising the budget. Resources keep on reducing, but still, the budget for family planning is still intact. The budget for RMNCH services has not been tampered with. So we are beginning to see a lot of attention, as I said earlier, and focus on the whole health sector, especially the vulnerable people, including even the care of the elderly people in Nigeria. So this is a big opportunity, and we hope to look for support, continuous support from the Global Funding for a GFA facility and all other development partners to see how we can best harness these opportunities and turn them into fortunes for the life of saving the lives of women and children in Nigeria.
Thank you so much, Dr. Thank you so much, Dr.
Thank you.
Thank you. So I think this is a perfect time to zoom out from the specific view that Dr. Salma was speaking to and bring others into the conversation, specifically around the role that development partners can play in this current context more broadly. Monique touched on some of the health financing challenges that we might expect to emerge from the pandemic and continue well into the recovery phase, the likelihood of a contraction in public revenues in many low and middle income countries, what can development partners do to support partner countries, and how can they incentivize governments to protect public spending on what we know are cost-effective SRH, but also other primary healthcare interventions. So maybe Prashant, would you like to jump in here, and then we can open up to others as well. And just before we move to you, Prashant, just a really quick reminder to our audience to continue to send in your questions. I have a couple of them in the queue that we'll turn to next, but just wanted to share that reminder with all of you. Thanks. Okay, over to you, Prashant.
Thanks, Janine. So one thing I want to remind us, and it's an agenda that is not entirely new, but I think is useful to go back to, is we desperately need a way to complement not just financing, but the procurement models that we use for essential medicines in general, but SRH products in particular, and a reliance on the two ends of the spectrum, one being just multilateral purchasing and globally pooled procurement through a UN agency, and on the other end of the spectrum, each country or each private sector entity purchasing SRH commodities on their own at less than efficient scale. I think we've got to find something in the middle of this, which would be national, regional, Africa-wide, many different models that we've explored in the past. And I think it's an important reminder that we need to create a complementary procurement model sooner rather than later. And that would help solve some of the upstream problems that I was describing on the supply side. The second thing, this is truly a global challenge, right? I mean, in the sense that, we face some of the problems that we are describing also in high-income countries and upper middle-income countries. And what we're seeing is that the supply chains for people who are urban, who are higher socioeconomic quintile, have progressed and are using technology. You can get your SRH things at home if you are a girl or a young woman in either a capital city or at a higher socioeconomic quintile. But if you are rural, if you are in a lower socioeconomic quintile, then none of those options are available to you. So it's once again a reminder to multilateral and others who work on development finance to think about can we use development finance effectively to take some of these newer technologies for supply chain delivery distribution that are currently only available to high-income groups, capital city, over to a larger swath of the population, to the vulnerable, and so on? And what would that mean? And I think both Marianne and Monique referred to a few, but that requires expansion. And a third thing is that while I keep stressing that there is a private channel for SRH access, we also need to recognize that in many countries, private distributors, because of the lockdowns or quarantine measures or other things, were not as effective to get product out to retail pharmacies, clinics, primary health centers as government response has been. And so in a way, I'm backtracking and saying government response is also an equally important part, and we cannot afford to not digitize or not enable government procurement and distribution to become state-of-the-art in its know-how, in its use of digital technology, latest supply chain technology, etc. And that requires a continuation of investments from development partners, which have happened, but maybe they require a slight rethink, a slight reorganization on how to do it. Over.
Thank you, Prashant. Let's turn to Marianne. I know you had some reactions and reflections based on Prashant as well as others' comments. So over to you, Marianne.
Yeah, no, thank you. I just wanted to quickly say, Prashant, and this is why, one, this conversation is so important, but two, the work that CGD is doing to, pull together all that is happening and have it inform longer-term policy, and also evaluate what's going on from an impact perspective is so important. But one example I just want to highlight based on what you just said. So one of the Merck for Mothers partnerships in Nigeria is around improving the capacity of local private providers in the SP space to deliver a broader array of services at quality. And this is including not just community pharmacists, but what have been the informal patent and proprietary medicine vendors, the PPMVs. It's a project called Integrate E. Through that project, they GPS mapped, all the different service provider sites. Those what were previously informal providers are now in a pathway to get formally accredited with the Pharmacy Council of Nigeria, working with the government. They're reporting into the DHIS system. But the point I wanted to make is because of COVID, the distributors to many of those networks sat down with the supply chain folks in the government and said, we need to figure out how to rationalize and integrate and combine our distribution networks because it's not working for either sector. And so that's just one example of an organic way that local private sector and public sector got together because of what the immediacy of COVID. And I think these are the learnings that we need to now, really investigate so that we can understand how and if they can be scaled. So to your point, post-COVID, how do we, help better complement, rationalize, integrate systems? Thank you.
Thank you, Marianne. So I'm keeping an eye on the clock and realizing that we are slowly but surely starting to run out of time. So I just thought maybe I would share a couple of questions we're getting coming in from the audience members and then turn back to the speakers. Feel free to pick up on certain angles or aspects that seem relevant, but I would just ask you all to share any final thoughts, both reflecting on the audience questions, but also reflecting on other points that have been made earlier in the conversation. So Monique made a point earlier about thinking in new ways, not only about what products women and girls will be accessing, but also how they will be accessing these products. And we have a question from someone in the audience about how self-care interventions might help be responsive might help in the current context of COVID in terms of being responsive to safeguarding sexual and reproductive health, and what might the private and public sector's roles be in specifically advancing self-care interventions. So I'll leave that question with you. We're also getting questions about what providers might be doing to help raise client awareness of service availability, which I think is something we've touched on earlier in the conversation. So I'll stop there and turn it back to our speakers just to share some really short final thoughts. Feel free to reflect on some of the questions or pick up on earlier comments, and maybe I'll suggest we start with Monique, and then we'll go to some of our other speakers before we wrap up. Thank you.
Great, thanks. And thanks again for this was a great discussion and such an important topic. So thanks for organizing it. I have a lot of closing, so I'll try and do it really fast, but they're a little bit dispersed, I think, all important and so on. So on the self-care, it really goes back to taking putting the woman central, right? And what are the needs related? And so in a way, I'm agnostic whether somebody accesses it through public services or private services, but we need to make sure, depending on the local context, that we provide a certain level of quality and that we ensure that women can access that without services without financial barrier. We are looking into those interventions, particularly around the family planning, that can be much more driven to the private sector, to self-care. But we're also looking at transformations in how primary care services are being organized. And there is really, in the medium term here, an opportunity to do things and deliver services in a much more client responsive way. And so, and one thing I haven't heard yet, I just want to put it out there, is that obviously we have a huge shared concern around the well-being of adolescent girls. And so when we think about innovations, the role of the private sector and all those other concepts, these girls are out of school now, right? And they are at home. And so, I mean, this has really shifted their vulnerability, and how do we address that in a smart way that is responsive to their needs? And then finally, I think more than ever, this world is changing in a way that even more clearly makes the point that we have to empower governments and their people to take their own decisions, to take the lead, to build their own capacity, to lead their own development, right? And I think that is now more clear than ever. And as a global community and a partnership, we're there to support that. Thank you.
Thank you, Monique. Dr. Salma, any final closing thoughts? I know you've shared a lot of important reflections for everyone to respond to, but I'll just turn to you for any final brief closing thoughts or comments. I think we might have lost Dr. Salma, so maybe Marianne, would you like to go next, and then we'll conclude with Prashant unless Dr. Salma joins us again.
Sure. Thank you so much, Janine. I think my point follows up from Monique's woman at the center, and how actually, as we see this increased utilization of self-care and self-care principles and self-care engagement, just goes to re-emphasize the point that we're not trying to solve for diseases. We're trying to solve for people and for health and for life. And we cannot continue to think about how we do this in silos and through vertical programming, because that's not how individuals, I think, want to engage in their care. The same channels we can use to inform adolescents about service points for SP, can be used to inform about sexual health, can be used to inform around education. And one of the things that it brings to mind for me is our ability to provide more self-care related integrated services also helps us go outside a zero-sum game around budget allocation, because if you're not paying for X, or to pay for X, you have to take from Y. So how is it that instead of going into these challenges using that mentality, we can think about how paying for Z actually solves for both X and Y? So I'll leave Prashant and the brains at CGD to figure that out. But I do think that COVID is, highlighting that, services need to be integrated because people seek services for a whole range of needs. And when you redeploy for COVID, you lose you have a detrimental impact on access to other essential services. Thank you.
Thank you. Absolutely. I think we could have an entire event dedicated to the points about, the zero-sum budget allocations and trade-offs in resource allocations. So more to come on that. But Dr. Salma has just rejoined us. So Dr. Salma, we're about to close, but I wanted to give you a chance to share any final closing thoughts reflecting on questions or comments that others have made. So over to you for your final words.
Thank you very much. I'm back now. I just want to emphasize of the opportunities, and part of the opportunities is for us to roll out the self-care so that individuals, families, and communities take responsibility, which is much cheaper, it's cost-effective, and we see that as another opportunity. The emphasis on observing the preventive measures is also another opportunity to push personal health care, which is also going to closely link with the self-care. So I see that as a great opportunity for us to rally around, which has been said earlier, the woman at the center of it. Then talking about the client's awareness is another big opportunity also to continue to emphasize on the client, the woman, and all the families around the woman to ensure that they all participate and they are informed, because now people have their ears open to listen to health information. So that also presents with a very big opportunity for us to help strengthen the health system at this very time, at all the healthcare levels, most especially at the local level, the primary healthcare level, the community level, where the services are most needed by vulnerable women and also by children. So this is all that I have to say, but it's a great opportunity talking to all of you, and then we look forward to how we can galvanize and have more developmental partner support to ensure effectiveness of the services that are being delivered at the level, including private sector. Thank you so much.
Thank you so much, Dr. Salma.
Thank you.
Thank you, especially for helping us end on a bit of an optimistic note, without any pressure on continuing that tone or not. Prashant, I'll hand it over to you for any final closing thoughts before we wrap up, because I am conscious that we're already a little bit over time. Over to you.
Thanks, Anit. So I'll be very short. So two things. One is, in the short term, we ought to keep a close tab on any shortages, disruptions, use our existing platforms, look at new data sources. So that's a short-term need. We cannot forget that. We've got to keep supplies coming in, services going. In the medium term, this idea of women and girls-centric delivery method and how the supply system will evolve and the supply chains will become omni-channel to cater to that is what we all ought to focus on. That will also accelerate the opportunities for use of digital, the opportunities for new business models, the opportunities for public sector changes and agility and things like that coming in. So I think if we build our efforts around that umbrella of women-centric supply and delivery models, I think we will get many of these things moving forward. Thank you. Great.
Thank you, Prashant, and others for highlighting where we and other colleagues need to keep our focus forwards. I said we're unfortunately at time. So much to discuss and not enough time, but I just wanted to end by saying thank you again to all of our speakers. We know this is a particularly busy time for everyone, so thank you for making the time to join today, and also to our audience. Stay tuned for a lot more work on these issues and important topics from CGD. So I'll just end by saying thank you and stay safe, everyone. Take care.